and diabetic patient, then you can use aspirin in these patients as the primary prophylaxis. So 75 to 80 you can use.
Dr. Dipesh, your slide is again unshared. And I think if you stop your video, then your voice can be more clear.
As with the AD also, they are also saying considering aspirin therapy for primary prevention in those with type 1 and type 2 diabetes at increased cardiovascular risk. So both guidelines more or less, they are in consensus that if patient of diabetes having high severity, then you can use aspirin as a primary prophylaxis, and that too in a lower possible dose of 75 to 100 milligram per day. And what about glycemic control? The guideline, again, they are saying hemoglobin A1C target is less than 7 or 6.5. It is again on an individual basis. And higher the hemoglobin A1C, that predict the higher CV risk. Now, hazard ratio is high in all subgroups. Fatal and non-fatal MI, amputation or death from peripheral vascular diseases, fatal or non-fatal stroke, as well as heart failure. They all increases with the higher hemoglobin A1C. So the goal is less than 7% hemoglobin A1C, and it depends upon the individual basis also. Then ESC says the metformin is recommended as the first line if tolerated. And now they have come up with the GLP-1 receptor agonist as well as SGLT2 inhibitor as the first line therapy, regardless of hemoglobin A1C as well as metformin. So CV benefit, if you see the UK PDS trial, over a 10 years period. However, as in previous talk, Dr. Alok was saying that at that time, the level of fasting as well as PP were a bit higher. But again, over a period of 10 years follow-up, it shows the significant proportion of patients, they have less chances of MI as well as death with anti hypoglycemic drug, sulfonylureas or metformin as compared to conventional therapy. So, material for diabetes, it was glucose approach before looking with different drugs. Cardio will come up with cardiovascular modification, and with this approach resulted in dramatic mortality in diabetes. And then no, with it is only not it is very fat which is also important. It is central obesity or organ fat, many complications of diabetes. So adipocyte, so now for
Sir, your voice is not audible. Sir, you are not audible and your screen is also unshared. शायद नेटवर्क इशू आ रहा है.
under monotherapy, influence A1C is not in above target, you can add metformin to the patient. And even if that is above target level, then you can consider for adding combination of two drugs or DPP-4 inhibitors if they are not on GLP-1 receptor agonist. Then you can add insulin or thiazolidine and sulfonylureas. Now, if patient is having not very high risk, then you can still use metformin as a monotherapy. And if that is not control hemoglobin A1C, then you can add DPP-4, GLP-1 or SGLT2 with other molecules.
Hello. Dr. Dipesh,
so the recommended treatment pathway for drug-naive patients is SGLT2 inhibitors and GLP-1 receptor agonists are recommended in drug-naive patient with the ASCVD or very high or high CV risk as a first-line therapy. This is ADA 2022 standard of care guidelines. The important point is first-line therapy depends upon the comorbidities of the patient and central factor including cost and access consideration and management needs. and generally includes metformin as a comprehensive lifestyle modification, because in India still the cost is the bar. So looking the cost of the GLP-1 receptor agonist now, this is again a contribution point. So this contribute to increase severity in diabetes type 2. A multifactorial approach is important to treat diabetes, recommended to address these factors, and they basically lifestyle modification, glycemic control, blood pressure, lipidemia control, as well as lipid inhibition. And last but not least is lowering medicine which have benefit as well as CAD based production. And treatment target and therapy should be depending on the and level of CADs.
को एक बार फ़ोन लगा के आप बात करेंगे क्या इनसे? कहिए कि अगर वाईफाई है इनके पास तो उस पे, हाँ क्या हुआ है? हाँ क्विट हो गया, मतलब कि कनेक्शन कट गया या उनका कोई कॉल आ गई होगी, तो एक बार उनसे बात करके देखते हैं, अगर वाईफाई पे हो तो अच्छा है क्योंकि लॉट ऑफ ऑडियंस आर देयर. हाँ, सेकंड ऑडियंस to, he can share the, yeah, watch it. हाँ 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 बिल्कुल.
नहीं वो भी बोल रहा हूँ साथ में ना, तुमको बता तो दिया जाए.
उनको वो डिस्कनेक्ट कर देंगे. डॉक्टर प्रवेश, अच्छा एक मिनट वेट कर लेते हैं एक बार जरा सा.
वो इनको लगा ना कैसे.
हाँ 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 बिल्कुल. सर
I think I should apologize to all of you. Probably my net connection was not stable.
I think that you can, Dipesh, you can summarize so that key take home message you can tell.
Yeah.
We can conclude that after that.
So, but basically, the last was many factors contribute to increasing CV risk in diabetes type 2. And there should be multifactorial approach in treating diabetes to prevent cardiovascular diseases as well. So lifestyle modification is important along with glycemic control, and blood pressure reduction target should try to achieve this, because many a times we are not able to accelerate our therapy to control blood pressure. Cholesterol level is important. That should again be targeted with the high dose statin as long as possible to reduce the complication with the pleiotropic effect of this. And drugs which have documented CV benefit.
ठीक है आगे आप.
ठीक है आप. Thank you. Now we are moving to the second speaker of the session.
Good evening. Now I will invite Dr. Previ Vishkarma, who is Professor in Department of Cardiology, KGMU, Lucknow. Sir, please start. Dr. Previ Vishkarma. कर दिया.
Am I audible?
Yeah.
Yes.
Hi everyone. A heartfelt thanks to the organizers for inviting me, and a very warm good evening to all the chairpersons and all the audience present there. So without wasting time, because we are already late, without wasting time, I would share my slides. Just let me know if this is visible in slideshow mode.
Yeah, it is visible.
Just a moment, let me minimize this. So the job given to me is to talk about management of ST elevation MIs in 2022 with some tadka of real life scenarios. Despite ST elevation MI being one of the most common emergencies we encounter in our day-to-day practice, there are certain dilemmas in management of ST elevation patients which keep on haunting or confusing us. Some of them, I will be talking about some of them. First of them is primary PCI versus pharmacoinvasive approach. We know that as per all the guidelines, primary PCI is our standard approach to any patient coming to us with ST elevation MI within window period of 12 hours. And this recommendation comes from several large number observational studies, randomized control trials, PAMI, Cadillac, Miami 2, and Prague. Even the meta-analysis by Keele has shown that this methodology is not only efficacious but also safe. There is an absolute reduction of 2% in terms of death, somewhere around 50 to 60% reduction in non-fatal MIs, and total strokes are reduced by half. So all these things led to recommendation of primary PCI being the current gold standard therapy. So it should be offered to all patients who come to us within window period of 12 hours or even up to 24 hours if the patient has gone or got ongoing chest pain or hemodynamic compromise. But there are certain challenges to this concept. Even in the best of the countries, the primary PCI is not 100%, or not all the centers offer the primary PCI at all the time. Especially in night times, the situation becomes grim. And from patients' perspective, there is always a lack of awareness. Patients as well as primary contact physicians are not aware that the primary PCI can be offered to them and which of the centers are offering the primary PCI. And in our country, especially in our country, financial constraints play a very important role. This is usually due to lack of personal insurance or even the government insurance. After this Aishman scheme, the situation has got a little better, but even some of the individuals don't have this Aishman gold card. So situation remains worse for all of us. Now coming to another strategy which compares with this primary PCI strategy is pharmacoinvasive approach. First, you thrombolize the patient and then you take them up for routine angiography within 24 hours. And this has been tested in a lot number of trials. I'll talk about the transfer MI trial, which was very landmark in establishing the role. Here, patients who underwent successful fibrinolysis with tenecteplase, and they were referred within 6 hours for routine angiography, and was compared to patients who were treated only with the fibrinolysis and they were continued only with the medical management. So as compared to fibrinolysis alone, successful fibrinolysis followed by angiography and, if need be, angioplasty led to significant 50 to 6% reduction in composite endpoints of death and MI. That means fibrinolysis alone is never sufficient. After fibrinolysis, successful fibrinolysis, you have to subject the patient to see what is underlying there, and you have to treat those lesions if they are troubling the patient and can cause a future re-MIs to the patient. Similar trial comes a large trial, stream trial, which established the role of pharmacoinvasive strategy. Here, the patients where the delay to primary PC was more than 60 minutes, they were randomized into two groups. One was the primary PCI despite the delay, another was pharmacoinvasive approach, thrombolysis with tenecteplase followed by routine angiography after 6, but before 24 hours. And in elderly patients, the tenecteplase dose was reduced to half midway